Bob make some comments, if you will, and we'll then go to questions.
Yes, thanks. Well, it's always a challenge to be at the end of the day and try to generate some ideas that haven't been said, but I'm going to pick up on comments that Christine made and follow up on some comment Jim Banian made right before the break. It's kind of interesting that my first grant I ever had funded 30 years ago was from the VA on appointment scheduling. Who would have thought? Wasn't a topic that was of great interest. In fact, senior leadership took me aside and said, you know, Bob, what you call waste, we call profit. So quit doing that work and do something else. But I've had the opportunity to live inside the operations research world and clinical medicine for 30 years, being an industrial engineer before I went into medicine. I've got to reflect on those observations and things that I've heard today. So it turns out that engineering, operations research, management science, applied math have really focused on the applications of methods in healthcare for over half a century. However, in building all those models, simulation models, queuing models, Markov models, other things, really require a deep understanding, a conceptual framework, and data that describe what is trying to be achieved. And what I'm going to talk to you today about is who needs what from whom, where, when, and how. And although this setting was to be about the how, I think what I'm going to lead you to is you can't really do the how well without these other things, and I'm going to go through those, because I think that's the foundation for how we can move forward. So too little work has been done on the who needs what from whom, where, and when to inform the how to create these models. Clinical investigators, clinical epidemiologists, and health services researchers have not focused on developing answers to these questions so that the modelers would have what they really need to develop and analyze their models and provide us with the type of information that they could and that we desperately need. There are multiple reasons for this: lack of funding interest, a lack of historical interest in healthcare system. Although we find places hiring industrial engineers now, you'd be hard-pressed to have found that 10, 20, 30 years ago. Not that we didn't need them, but healthcare systems didn't want to spend the money hiring them because they saw it as a cost. Engineering students weren't stupid. They went into healthcare financing, management service, manufacturing, defense, and so on. So we never had that group of talent. There's a lack of understanding of the engineering, operations, research, and applied math by clinical investigators. Those fields don't mix very well. That continues to be a problem today that I'll get back to in a few minutes. Well, these issues can be addressed, and they need to be. There are groups now, and you've heard some of them today, being formed at institutions where you have clinicians and engineers and operations researchers, management sciences, bridging these professions together and getting things done. There's often, however, a disconnect between clinical operations and scholarship at a lot of places. You've heard Hopkins now, Mayo, some others are funding these clinical scholarship intersections with hospital operations dollars, but that's been few and far between. And that's a deep funding source that needs to be tapped to be able to bridge these things together going forward, but it's kept a problem in the past. So it'll be important to meld those together. Now, getting to the who, I'm going to talk about individuals, not going to talk about patients. Now, individuals who are part of a population for whom we're seeking to achieve the best possible health are characterized by multiple domains that might generate a health assessment and intervention: age, comorbidity, a physiological parameter, such as an elevated blood pressure, but social support, pattern of health behavior, their environment, their genetics. There are at least 30 separate factors that could go into creating these domains of what might generate the need for an interaction in healthcare. It could be someone other than who we think of as a traditional patient, such as the family or the caregiver, and we heard about those systems. So that's part of the who of the systems that we need to think about. And we haven't thought about that well enough, and we don't have those sub-classification systems to create those individual views of who we're trying to take care of. So we need a much richer characterization. And from that, we can do lots of probability predictions. We can probably predict better about who's going to take how long and what needs are they going to need and what types of care do they need. And I'll get into that second, which is the what. What do they need? Well, outpatient clinical care has predominantly been delivered through physician or nurse practitioner or physician assistant clinic visits. Why? Because that's how we've been paid. This is the care that happens in that visit is really a legacy approach handed down through decades of apprenticeship approaches to learning. Ask somebody why you do that. Well, that's what my fill in the name, attending, resident, intern taught me what to do. And there's very little in the literature about what needs to be addressed at any specific visit, unbelievable enough, conditioned on the many current statuses of these various domains of these relevant factors. We just heard what is in the content of a lot of these visits. A lot of it is waste. Why is that? Well, we've never studied and looked at what we really should be doing. You open up a textbook of medicine, it's not in there. There's a lot that are not in those textbooks, by the way. Most of the stuff that you really want to know what to do and what to tell patients doesn't happen to be in there. Lots of physiology and biology and chemistry, but not a lot to really guide what we need to be doing. So an exam, for instance, might include a history, a physical exam, a review of physiologic parameters, motivational interviewing, counseling, a discussion of prognosis, shared decision-making, developing a specific actionable plan of care for the providers and the individuals. Now, we know that the usual visit might not be of sufficient duration or efficiently organized to address these issues. So what are we trying to accomplish? We really need to know. Then we get to from whom. Once we figure out what we really need to accomplish, as mentioned, many people are doing things they don't need to be doing. We're not efficiently deploying our labor mix as well as we can. Reimbursements have influenced care to be provided by the physician, the nurse practitioner, or the physician assistant, because that's where the money comes from. It has to be a visit in order to get paid. So even though we inconvenience patients, and physicians may not, or physician assistants, or nurse practitioners may not even be the best trained person for what you're trying to accomplish. It might be a pharmacist, a health educator, social worker, an RN. We aren't organized to do that for the most part. So care coordination teams are being created to distribute the care according to the appropriate care provider. But unless we know to whom we want to schedule a care need interaction with an individual, we will create a very efficient scheduling approach for the wrong care system. So this is much like using information system and informatics to make really efficient a bad system, where we can make really efficient scheduling for the wrong system. Now I'll add where. Again, the office visit has been the traditional setting of care because that's what's gotten paid for, but it's clear an office visit isn't needed for a lot of things that takes place. My physicians don't know what they get mad at me when I say on the one hand, we need to crank up your visits because we need money, but I've got this great deal for you. You don't need to have these routine, easy patients with hypertension come to visit because I can take care of care coordination. But those are my easy visits where I can do this for you. And so they're, in attention right now because there's been no alignment of the payment systems to really promote the right kind of care. Maybe with CMS's new care coordination per member per month fee that's going to come out and roll out January 1st, that'll help ease some of that pain and we can move forward. But a lot of things can happen in different settings, and some places are starting to use those different settings, and we need to proliferate that. But again, if your scheduling system doesn't acknowledge the different settings that can be utilized, you're not going to have the right system. Then when? There's been historically very little research and little evidence-based guidance for selecting time intervals for about anything we do. And as I remember as a resident, I was excited about two things. When I bring somebody back to check their potassium, when I start hydrochlorothiazide, because there was some data, and when I would get a repeat chest x-ray on somebody who was hospitalized with pneumonia because they told me this is how long it would be before the radiograph ought to be clean, right? And it was hard-pressed to find any other data for any other decision that we made about picking a time, including when you bring people back for a colonoscopy after you snipped out a small polyp. Oh, every 2 years. Why is that? Well, that's what they told me. Well, it turns out you've clogged up the entire system of colonoscopy, and so all the people who need the first ones can't get in because you're doing all these ones of people that don't need it. But that was happening for a long period of time. You would think the textbooks of medicine, surgery would have time in there, but we haven't done research on time. Nobody's been interested in time. And yet time is a critical element that we really need to be able to do if we're going to understand scheduling what and when. If we can't tell the engineers and operations researchers what we really need to be doing and when, they have really fancy techniques and mathematical models that can do stuff, but if you don't have good stuff to put in, you get not very helpful stuff on the outside. And finally, the how. And the how is what this meeting was thinking it was going to be mostly about. And it's what operations research, industrial engineering, management science, and applied math have been doing for a long time. Now, I was just at the INFORMS meeting, the International Forum for Operations Research and Management Science, 2 weeks ago. 5,000 people. It's their big international meeting. And it's been going on for a long time. It used to be called ORSA-TIMS, Operation Research of America, Institute for Management Science. And I've been looking at that for many, many years. And there were 4 tracks, 68 sessions, and over 200 individual presentations. About 25% of them addressed issues related to scheduling, by my count, going through the program. But much of that looked the same as it would look 30 years ago. The methods were a little more sophisticated, but there were some problems. One, a tractable problem was presented, but it was perhaps the wrong problem. The data to the models, as I've just mentioned, were very sparse and often of questionable quality. There was a limited understanding of healthcare too often, sometimes not. Some of the OR stuff has been really great. There's places where the anesthesiologists, the surgeons have been doing scheduling and so on really tightly, but that's a less common. More common, you have people that really don't know exactly what the real issue is, but they're really excited about the methods and the math. And so there's been this limited collaboration between those groups that we really need to push, go forward. And as a result, as you might guess, the analysis, the interpretation of the output is often limited relative to the opportunity because of the lack of this ability to really understand what the issues are. So I think we need to encourage, facilitate, and support these close interprofessional collaborations between the engineers and the applied math scientists and the clinicians. Lots of ways that can be done. I won't get into that right now. I did have 4 areas, though, in this modeling area that I thought that people ought to start looking at in terms of advanced complexity, so I couldn't resist putting on my engineering hat. The first is the time dependency of the relationships, the values of parameters. So time-dependent variables are very relevant in healthcare, and they're complicated in models, so people tend to ignore them, but that's just not the reality. So I think we need to think about that. The second is to generate the recognition of flexible constraints. So too many of the optimization models, to make them look analytically, they have fixed constraints because then you can solve the problem with traditional math, but that's just also not the reality. Reality is there are flexible constraints and certain boundaries around that, so we need different kinds of optimization approaches to deal with the reality of that's what healthcare is. The third is to expand the understanding of the multi-attribute objective function, and we heard about that earlier today, where we're trying to optimize multiple competing objectives, and so that needs to be fleshed out more. There was a discussion of the 50th anniversary of decision analysis at this meeting, and Ron Howard and Howard Rayford were there giving a talk and talking about what the next future of decision analysis ought to be for the next 50 years, and was really focusing on the need to really get a better handle on the multi-attribute optimization and the objective function. And that is healthcare, true and true. The fourth, and picking up on what Zelda presented, was one of the outcome measures. So too often I think we use means as outcome measures and not the percentage above an important threshold. So you saw in one of our scheduling the percentage of people who waited more than 10 minutes as an interesting outcome measure. But a lot of reasons that those don't get used with engineering is we have to pick a threshold that has some significant clinical meaning, and we haven't done the work to try to sort out what those significant clinical meaning thresholds are. But I think we can include those in, we'll have better modeling. So, in summary, I believe we should expand our view of what is included within, surrounds, and influences the broad area of scheduling. It's not just about more sophisticated analytical techniques and bringing those techniques into medicine. Those techniques have been brought into medicine for 50 years. We need to do a better job of integrating together, collaborating, understanding what that is, and get our traditional evidence-based gatherers excited about this area so that we can inform all of these areas rather than just the how. Thanks.